Hello, everyone. So great to be with you again this evening, where we're going to have our second installment of our series around the National Osteopathic Medicine Week. Tonight, we will have Jessica Bandari, who will be our DO Advisory Board Chair moving forward into 2020 and 2021, leading this session tonight. So excited to hear from current residents right now who went to osteopathic medical schools. And I know that I'm going to learn a lot tonight, and I look forward to listening in. So Jessica, without further ado, I'm going to turn it over to you.
Hi, Isaiah. Thank you so much. My name is Jessica Bandari. I'm third year at the Alabama College of Osteopathic Medicine. I went to Texas A&M for undergrad, and I'm serving as the chair of the DO Advisory Board this year. We put together these kind of webinars in honor of National Osteopathic Medicine Week. We just wanted to talk about, for our session today, we're going to be talking about osteopathic medicine in practice. How do physicians who are practicing currently use OMM, and what type of tips they could give to students who are interested in OMM or trying to figure out if they'd be interested in going into DO school. And without further ado, these are our speakers, and they'll go ahead and introduce themselves. I just wanted to point out one of our speakers couldn't make it today, but she did try to give us some of her insights, so we'll try to put that in as we go along. And I'll just let you guys all introduce yourselves.
All right, I guess we'll go from top. So my name is Anish Parmeshwaran. I am also a graduate of Alabama College of Osteopathic Medicine, and I currently am a resident at St. Luke's Internal Medicine University Health Network at the Anderson campus in Easton, Pennsylvania. I actually went to undergrad at NJIT. I did biomedical engineering there, and then went on to ACOM afterwards.
Okay, my name is Shane Menzies. I am a fourth-year student at the Alabama College of Osteopathic Medicine. I'm going to be graduating in about a month. As you can see, I matched into emergency medicine at Metro Health, University of Michigan Health in Wyoming, Michigan. I did my undergrad at Oral Roberts University in Tulsa, Oklahoma, was actually a multimedia production major, non-traditional student, had a couple careers before med school, spent about 5 years as a patient registration rep in an ER back in Sarasota, Florida, before coming to ACOM.
So since Amanda's not here, I'll go next. My name is Jonathan Carbunco. I am a third year at the Alabama College of Osteopathic Medicine. I am also one of the current anatomy and OPP fellows, along with Hunter Green.
Hey everyone, my name is Hunter Green, like the color. I am also a third year at ACOM, and I'm one of the anatomy and OPP fellows. I'm from St. Augustine, Florida, and I went to Stanford University for my undergrad. I was actually a music major, and worked in a hospital for 2 years before arriving to ACOM.
All right, thank you guys so much. So we'll kind of move on to the first question, which is actually, what is osteopathic medicine? And we throw around a lot of acronyms like OPP, OMT, OMM. If you go to an osteopathic school, you're familiar with these, but if you're not, we just wanted to clarify those before we move on. So Jonathan and Hunter, if you guys could help us out with that.
Okay, so OPP stands for Osteopathic Principles and Practices. That is talking about the course that we take when you're in DO school. So that's where you learn all the manipulative techniques, and along with, so there's usually a lecture and a lab component. So for OMM stands for Osteopathic Manipulative Medicine, and OMT stands for Osteopathic Manipulative Treatment. Those two are kind of interchangeable. So as far as what is osteopathic medicine, so the actual physical aspect of it is using the body to stretch or to create positions of ease to help relieve pain, among other things. But what is osteopathic medicine, like capital O, capital M? That tends to refer to the 4 tenets of osteopathic medicine, which is our care is kind of based around that. So those really quick are that the body is a unit made of mind, body, and spirit, or the person is a unit made of mind, body, and spirit. The body is capable of self-healing and self-regulation, that structure and function are interrelated, and that reasonable or logical treatment is based off of those other 3 tenets.
Awesome, John. Go ahead.
Sorry. So just big picture, a lot of the theory behind osteopathic medicine is just recognizing that we as doctors are not necessarily healing the patient, we're helping the patient heal themselves. So just integrating that into our care and recognizing that at all stages.
It's awesome. We have these fellows who know exactly the depth and detail that we're interested in. So I hope that helped clear up some confusion about OMM. So our next question is for Dr. Parameswaran. So can you tell us what a typical day like is in residency?
Yeah, so it really varies per what residency you even do. So I'm actually internal medicine, and so within internal medicine we have separate rotations. If you're inpatient or ICU, or you're some sort of electives where you do some of the specialties like cardiology, pulmonology, GI. But for the most part, all of the rotations in internal medicine start out. We start out at 6:30, get there. Kind of pre-round, pre-chart, and then at 7 or 7:30 we do an hour of morning report where residents or attendings even present cases, and we have a kind of like a live discussion of this is what the patient presents with, and everyone just gives out their ideas. It's really nice because it's a good learning experience, and I for one definitely kind of take in a lot from those that feedback that I get from my attendings or even my colleagues, because the next time I see a patient with similar presentation, I start thinking, oh yeah, that's something that other person mentioned to me that could be a possibility. Anyway, so that's morning report. After that, we have we'll pre-round, we'll finish pre-rounding on how many of our patients we have, and then we'll round with our attendings. If our attendings are not yet ready to round, we'll work on our notes, get our notes done, we'll put in our orders, talk to case management about disposition, discharge planning, things like that. And then after we round with the attending, we get a finalized plan, make adjustments to our note, submit that note, have them co-sign it, and then by that time it's around lunch, and you quickly grab a bite, and then you try to finish up your other notes, make some calls to family, update everyone with what's going on, and then you're ready to take admissions. So you'll get about 1 to 2, maybe even 3 to 4 admissions if you're on call, and then based on whether or not you're on call, your day ends at 4:30 or 8 if you're on call. So you end up working around 10 to 14 hours in a given day, at least on inpatient medicine. And with ICU, just the hours are a little shifted. It's about 12 hours a day, but more or less the same schedule. And so by the end of the week, you kind of really exhausted because you went through 5 or 6 days, and then you get 1 day off, and you start it all over again.
That's awesome to hear about the inpatient medicine side. I know Shane probably knows more about emergency med and how the auditions worked. So could you let us know about that, Shane?
Yeah, so I only did auditions for emergency med. And so a day in the life on that is basically most days during your audition, you're going to be on shift. The shift can last usually anywhere between 8 and 12 hours. It depends on the program you're at, how long their shifts are for their residents, how long their shifts are for their med students. Depending on the program, you'll either be paired with an attending or a resident, or if it's a big enough program, possibly both. But for me, again, a lot of programs was with residents, but there were some particularly newer programs where they would just put you with an attending, and you'll see a patient on your own and then present the patient to either your resident or your attending, or the resident and then the attending if the resident liked your presentation. So that's usually a good sign if they ask you to present to the attending right away. The main idea is they really, they want to see how your information gathering is. Your assessment and plan, they want you to have one, but it's not as important to them as to what it is initially. They just are trying to get your thought process, so they don't care if you're wrong. The good part about that is that everywhere I was, they made a pretty big emphasis that there's not going to be a lot of pressure. And then usually one day a week, you'll have didactics for about 4 or 5 hours. just a series of lectures and workshops that all residents, or for EM residents, you typically do it one morning a week. And I know different residency programs and different specialties, they might carve out like an hour a day throughout the week to do, like 5 days a week or so. But for all the EM programs I was at, it was just pretty much one morning a week.
Awesome. So that sheds a lot of light on how EM works and how IM works. So we can go on to our next question. Does your program have osteopathic recognition, and what does that mean exactly? And if so, like what is the difference that you've seen in your curriculum versus other residents?
So for me, for the EM program that I'm going into, they had been an AOA program until last year. I think last year they switched over to ACGME a year before they were required to. And in such, I think about half the programs at the hospital have osteopathic recognition and half do not. The emergency medicine program is one of the ones that does not. So even though it's a predominantly DO program, I think they took one MD last year, and I think that's the first MD they've taken so far. They don't have osteopathic recognition, but as such, like most of the faculty are DOs. So there's still opportunities to do OMM, even though technically the program doesn't have osteopathic recognition.
Yeah, I'm technically in a non-osteopathic recognition program, mainly because the program, so St. Luke's has two separate internal medicine programs. One is established at their main campus, and I'm at the newer campus at the newer program. So the original campus with the original internal medicine program is osteopathically recognized, and we're working to gain osteopathic recognition at our campus as well. So with that, we have the same requirements for any residency having osteopathic recognition, and that means we have monthly OMT sessions actually across multiple hospitals in our network, and so all the residents kind of conglomerate. Well, not anymore, but we used to meet up every month or so and practice OMT, of course, under the guidance of attendings that are certified in osteopathic medicine. And then in addition, we also have separate clinic days. So I have normal clinic days where I see my patients that I say discharge for whatever condition they have that I see afterwards. But then I have separate days where I primarily only do OPP. And that's pretty much what is involved in our program right now that's osteopathically recognized, in addition to, of course, research based in osteopathic medicine.
Well, that's awesome that your residency is letting you, kind of do a lot that you've learned through your osteopathic degree. I'm glad that you're able to do that. And this kind of leads into our next question, just to tell us a little bit more about third and fourth year experiences and being able to apply OMM on rotations. This is something that I personally am always trying to do. If anyone who knows me, all of my attendings have been awesome and great, and all the patients are very interested and excited to know what I can do to help them. So you guys could let us know what y'all think too.
For me, it was, like you said, you kind of have to be looking for opportunities to perform OMM. Sometimes opportunities will fall into your lap, and you have to be with a preceptor that's open to it, which fortunately I've been able to work with plenty of those. Plus at our school, ACOM, we have to do a couple OMM SOAP notes throughout third year. So that kind of gets you in the mindset of being able to look for opportunities to do OMM. And even in fourth year on auditions, in EM, I had a couple opportunities to do OMM, both as a screening tool and as a treatment modality. I remember, I think it was my fourth audition, my preceptor was actually an MD, and then he was giving me a hard time once because I had a patient with low back pain, and because I didn't automatically jump into OMM mode as far as like diagnosis and treatment with, coming up with my assessment plan. So I had to go back into the room with the patient, which on rotations, you kind of get used to, if you're going back to see a patient, it's because you forgot to do something or forgot to ask something. So that was a humbling experience, but a good one.
Yeah, I'd like to add to that. Very much so with what Shane said. A lot of times osteopathic or allopathic attendings would both kind of get excited when they see that you're comfortable in performing OMT on any of the patients, and especially if they had, like Shane said, low back pain or any sort of pain that we could treat osteopathically. They really did. I was very surprised that they were very kind of forthcoming, like, hey, please, you can help the patient with this. Let's see how we can. And sometimes they would also ask me to kind of show them if they were a little rusty. It'd been a couple of years since they practiced it, so it was a humbling experience to do it, but it was also exciting to be able to kind of teach your attending a little bit something.
Something that I've personally thought is really cool with OMM in general is that if you can break it down and explain it to your attendings, most of our attendings are MDs, and say, like, this patient's anatomy is doing this. This is what happens physiologically, and we're just going to work on it by moving the muscles, moving the bones a certain way. All the attendings are usually on board. They're like, oh yeah, totally, that makes sense. We learned that in anatomy back in the day. And so I feel like that's been a really good way just to get more attendings interested and, presenting them with the plan and logic of what you're trying to do. So we can go on to the next question of how did you guys get good at OMM, and how did you get comfortable using this on patients?
I can start with this one. Go ahead, Shane.
Well, I'll just be quick. I think just doing it more, and obviously spending that year as a fellow, we got to work in the clinic. We got to, help out in labs. I think just repetition, the more you do it, even like in lab, where people don't necessarily have a lot of problems or a lot of somatic dysfunction, you get used to what normal feels like. So when abnormal shows up, it's easier to figure out.
So to add to that, so part of the ACOM Anatomy OPP Fellowship is that it's a teaching fellowship. So we're actually teaching OMM to first and second year students. So something that I found a lot teaching, and also as a student, just exactly what everyone keeps saying, the more you practice, the more body types that you work with. If they're much larger than you might have to modify the technique to work for that patient. Or if they're much smaller than you might have to be a little bit more gentle or pick a different technique for that patient. So the more you do, the more confident you get, and the more times that person gets up off the treatment table and say, oh, wow, I feel better, that really reinforces the skills that you've learned. And I think probably the times where I've gotten the most good at or most confident using OMM is just treating my friends and my family and stuff like that. So they'll give you honest feedback. They'll say, oh yeah, that didn't do anything for me, so try something different. So you learn the techniques in class, but you really have to just find your own confidence outside of that.
Yeah, kind of adding on to what both of them said is that you kind of just practice. The more you do it, and the best way to get more exposure and more experience is, especially in your third year, kind of just find an excuse to do OMM on a patient. Of course, as long as it's indicated, but don't be scared of asking your attending, hey, this is something that I think this is a somatic dysfunction we can look at and maybe work towards. And a lot, like I said before, a lot of times the attendings were like, oh yeah, this is definitely good. Keep doing it. So I think just getting yourself to pushing yourself to just do it, even though you may not feel confident right now, that'll build that confidence.
Just wanted to pause a second. Can we go back over, start back from the beginning? Can y'all explain somatic dysfunction? So we use that word a couple of times, but there's pre-meds here that might not know what that means. So let's backtrack just a little bit. Anyone?
I know one of you guys still know the definition word for word.
So I am not that person, but so somatic dysfunction is basically, an easy way to think about it is your body has normal physiology. It has the way that it likes to move. Somatic dysfunction is when your body is misbehaving, if you will. So it's doing something that it doesn't like, whether it's an injury or from a chronic overuse pattern, something like that. Your body gets stuck in a way that is not optimal. So that can cause pain, that can cause a restrictive range of motion, that can cause asymmetry and stuff like that. So when, as a DO or as a DO student, when you're looking for what problems your patient might have, you're going to look at four things we call TART. So tissue texture changes, asymmetry, restrictive range of motion, and tenderness. Those four things are kind of the definition of somatic dysfunction, and those are the things that we look to improve with our treatments.
Awesome. Thank you for that clarification, Jonathan. I think that really helps. We wanted to move on to the next question about billing. Personally, for me too, I've heard a lot of people, once they get older and into practice, they're like, well, I can't bill for that, so I'm not going to do it. Or I don't know how to bill for that, or it's really complicated, or insurance doesn't pay for it. So we just wanted to know, if you're using OMM, like how is this reimbursed? And
yeah, so at least in our clinic that I was mentioning, where we do primarily OPP for that day, the way it works is that you would say someone comes in with a shoulder pain, for instance, so that you have to have the proper ICD-10 codes. I'm sure you heard these buzzwords, these codes that kind of are symbols for diagnoses that we see. So a shoulder pain, like I said, a right shoulder pain. So that'll be whatever that dot number code is, and that'll be the primary diagnosis. So I'll say that's a right shoulder pain, and then I'll give a quick assessment and plan on that, and then subsequently I'll say, well, there's a restriction in motion or somatic dysfunction actually of the right shoulder. So and then in that diagnosis, I can actually talk about what I found, what kind of tissue texture change or asymmetry or the TART that I found. And then in the plan, you talk about, okay, this is what I did. I did the Spencer's technique. I used counter strain. I used muscle energy, whatever you use, or HVLA if that came to that. Then you would just document that, and then you do the same thing. And I believe the rule, at least for our clinic, is we have to have 3 separate areas that are documented and treated, and that kind of makes sense because, as we know our law of tensegrity, where everything is connected and things are pulling on each other. Because of that, we can't just treat the shoulder. We're not just kind of honing in on that. We have to look at the centrally too. So we'll look at the T-spine, or we'll look at the neck too if it's radiating to the neck, the pain. So now we have 3 separate areas. I've treated the cervical, I've treated thoracic, and I've also treated right upper extremity. And then after you put all those diagnoses in, with the top being shoulder pain, then you, in terms of billing, you'd bill it as a standard visit. And there's, again, you'll learn this as you enter residency or maybe even in 4th year. And then you add what you may have heard about in your OMT lectures, modifier 25. That means that you actually utilize osteopathic manipulative treatment in your visit. And if someone else would like to add on to their experiences too, please.
I think you're the only real doctor here. So so once we get out in practice, we can definitely ask you again and look up this video. Thank you for that. That's a question that I've been asked a million times and I never know the answer to. So we can move on to our next question. Can you guys walk us through a patient case? Just one each. If you guys have a good case, we have some time just to kind of give people a good idea of what we're actually talking about here.
So I remember the first time that I used OMM on rotations on a patient and it helped. I was on my OBGYN rotation, and I remember I think the reason I remember it was just because how random the circumstances were. The patient I was just working in clinic with my preceptor that day. We had a patient, she just came in for her annual, GYN exam, and she mentioned she had neck pain. And then my preceptor was all too happy to offer up the DO student to take a look, since, he had some time before I think the next patient was going to come in. And she stated, she'd been having this neck pain on and off for about 10 years, but it had been getting worse. So I was like, okay. So had her lay down, did some range of motion tests, came up with a diagnosis, tried some counter strain. She said it felt better. And so I was like, okay, then. And so, and that, again, I think the reason I remember it was just because it was like, not something I was expecting to do when I came into clinic that day. But I guess it just goes to show that, just be ready for anything when you show up for rotations, and all that experience that you get in OPP lab for 2 years, it comes right back.
So as fellows, we get to take part in rural clinic that ACOM recently just opened. And I got to see a patient who had come in. He had been having low back pain, and it was radiating down one of his legs for like 3 or 4 months after sitting too long at a football game. But it was chronic, and it was making it very difficult for him to work. He would have intermittent numbness and tingling of his leg and stuff like that. So it was kind of scary to him because he really wasn't sure what was going on. So in examining him, making sure he didn't have anything crazy like a herniated disc or anything like that, I got to do some treatment on him, working on one of the muscles in the gluteal region, so the piriformis muscle. For those who aren't familiar, it tends to run over the sciatic nerve, which is what can cause sciatica type pain. It goes through the low back and typically down one of the legs. So I worked on that muscle with him with something called counter strain. The idea is to like shrink up the muscle as much as possible so it recognizes like, oh, I can relax now. Also working with his hip bones as well, because in sitting too long, they can become misaligned from one another and cause similar issues as well, and cause the piriformis to be more tight. Just in one visit with him, we were able to reduce his pain from what he would consider 8 out of 10 to like a 2 out of 10, but then also relieve the numbness and tingling that he had been experiencing for the first time in 3 months. So he walked out of that visit very, very happy, where he was struggling to sit on the table to begin with. So just to be able to get that much of a relief out of a patient, in following up with him, it didn't hold. He needed some more treatment, and we did that with him, and he continually progressed to get better. But just to be able to make such a difference in one visit is awesome.
So another thing that we get to do as fellows at ACOM is something called CODE, which is Comprehensive Osteopathic Demonstrative Events, I believe. Basically, we get to work on other students and teach and treat them under supervision of our professors. So I remember one time at CODE, a student came up to me kind of frantic about just before her exam, and she had a really, really bad headache that had been affecting her since the day before. It was affecting her studying, all that stuff. So I love treating headaches. I don't know why. Well, it's because I get headaches all the time. So I've gotten pretty good and comfortable with those techniques. So after like a 15-minute treatment, I was able to knock her headache down from like a 10 out of 10 to like a 1 or 2. And she had also taken like some ibuprofen right before that, but 15-minute treatment was pretty successful with that. So that's the nice thing about using these skills, is that a lot of times you supplement regular medication. So of course, if someone has a headache, take some ibuprofen, of course, but if you can help them a little bit faster and maybe knock their headache down or make the medicine last a little bit longer, that's a cool thing to do for your patients.
Yeah, I think to go on with what Shane was saying too, in OBGYN, I had an experience where, of course, back pain is especially in pregnant females greater than that have been pregnant for quite a bit of time, almost about to give birth. So they have this continuous back pain, and it was unrelenting. And so there's one technique, the facilitated positional release. They just have to lay down and just push down on their knee as it's just slightly flexed, and kind of push up, and that provided quite a bit of relief for the mother to be, and to the point where she would always, or many mothers that had this, they would encourage me to teach their spouses, their partners, so that this could be done at home. So that was a pretty cool experience.
It's awesome. I just want to share one more story. So I've been treated at Code, especially by Amanda back in the day whenever she was one of our fellows. And just for women in general, I know girls have a lot of menstrual pain and people don't like to talk about. But there was really cool OMT that she was able to do on my lower back to help with that. And I'm only speaking to this because it's something that's not talked about a lot. But I'm somebody who takes tons of ibuprofen. But this is, you know, a different type of pain. So there's definitely a role for OMT in that too. So we can move on to our next question. Is there a specific resource that you guys use to pick your OMT? What do you like? How do you guys know what you're doing is correct? What would you recommend for students who are interested in learning more?
So for me, one thing, and this was something, the year I was a fellow, we spent basically half of our year working on is our school's OMM video library. And that's kind of been my go-to resource ever since we put that together. I mean, I'll go back to a textbook like Nick and Nick if I really want a more, I guess, in-depth or book explanation. But as far as like just performing a technique, our school's video library is usually where I like to go. Hopefully there are other DO schools out there that have video libraries. I'm sure some of them do. I think just with my learning style, I'm a visual person, so that helps, but that's pretty much been my go-to resource.
I tend to ask Hunter usually if I don't know what to do, but if Hunter's not around, there's a book called The Pocket Manual of OMT, and it's literally like pocket size. Actually, here, it's like this size, and I really like this book because it's separated by like body region, and it has different techniques for each region. So if I know that my patient has a shoulder problem, I can flip to that section of the book and try to find a technique that will work best for that patient. So that's what I tend to use.
That's a great resource. I know I bought that book because Jonathan told me to. So it's definitely been useful to have in clinic, and I actually gave it to my clerkship director who was interested in learning more about OMT. He's an MD, and he was really excited that he got access to it. So we've been trying to talk about it during didactics before they were canceled because of COVID. So we'll move on to our next question, which I is missing, but that's okay. Let's talk about the question that I had written down. Are there any pitfalls that you've seen with students or interns who have been working with you? Anything that you suggest that students should continue on? This is for Dr. P.
Yeah, no, I think especially in your so I'll go backwards. So from pre-med, definitely go out and kind of make yourself available to see if you can shadow physicians, osteopathic or allopathic. Kind of just get yourself out there, get that exposure, and that's something that's always looked well upon. And then for med students, what I would say is kind of when you're on your rotations, definitely work with the intern or residents and see what you can do to help the team, because you're kind of and again, this is primarily, I can only speak on behalf of internal medicine, but you're always working on a team as a team. So if something needs to be done for the treatment of a patient or something or the other, having another a med student there to kind of make the calls or whatever needs to be done is always looked well upon. And we always remember those students, especially come match season, when we're like, hey, I remember that person. They were really kind of gung-ho about helping us. And same for interns. As an intern or as a resident, it's all about being a team player, especially in internal medicine. I'm sure in other specialties as well. So because if you're unable to kind of pull your weight, a lot of times your partners or your teammates have to make sure that the job gets done. So it really helps to be a good team player. And definitely if you have some free, like a lot of times if I get my work done earlier for the day and some of my colleagues are struggling with a bunch of more difficult cases, I'll be like, hey, you know what? Let me just make some calls for you, kind of help you out. And my friends do that for me, and we do that for each other, and that really goes a long way, and it kind of builds that relationship, especially amongst residents.
Awesome, awesome. So our next question, which is already up here, what advice would you give to your pre-medical self, or anyone who's hesitant about applying to DO schools? Like, I don't know any DOs, I don't actually know what this is all about. What would you say to them?
So something that I kick myself for to this day is if you have the opportunity to in undergrad, take anatomy. It will make your life a lot easier in the long run. I had not taken anatomy before coming to ACOM, and I severely regret it because it is just a big chunk of your curriculum, and it will take a lot of your time, and any familiarity you have with that is way better, and it'll put you way above where I was. So another thing, if you're thinking about applying to DO schools but you don't know DOs, well, first thing is use the resources that are available. Double ACOM and other resources have lists of DOs that are in the area. So try to find one. And if you can't, just make sure you do your research and try to talk with medical schools or medical students who are DO students, and just get as much information as possible, because it just, as it happens, DOs are less common than MDs, and that is what it is. But showing interest and trying to get as much information as possible will take you a long way with that.
I will
Definitely. Oh, I'm sorry.
No, you're good. Go ahead.
Yeah, definitely shadowing, the resources that Jonathan was talking about, as well as I remember using osteopathic.org, and I just kind of looked up who was in my area and made a bunch of cold calls, and it took some time, but I was able to find some attendings that were able to kind of take me under their wing, and I really learned a lot. And I did the same with allopathic and osteopathic. So it's just, there are a lot of attendings that are willing to kind of teach.
Anyone else? Go ahead.
So I was a scribe before I started at ACOM, and I worked with both MDs and DOs, but just because of the nature of RER, a lot of the DOs didn't really get to practice OMT. Like, I didn't really have any understanding of what osteopathic manipulative medicine was. But even then, coming into a DO school, it was okay. Like, this is where you learn about that stuff. So even if you don't have a solid understanding of it coming in, you will learn it through your time here. You want to get some of the background to know what you're getting into, like maybe look up the philosophy a little bit of like why we do what we do, but like, you are not expected to know how to treat patients coming in. You are not expected to know these techniques or like the different things that we do. More of just the, maybe even a little bit of the why behind it. But yeah, don't worry, guys.
I think I'd agree with everything that they've said. And second, the anatomy. I did not take anatomy as an undergrad because it was on cats and I didn't want to take it. But I definitely would have if I had the option, or somebody told me from future. And just so everybody knows, you guys can add some questions as we reach the end. We'll add them into the end. If you're watching, you can add some questions, put them in the Facebook chat, and we'll address them as well. Here was the question from earlier. So I have another question for our OMM fellows. Why did you choose to do the fellowship? Are you glad you did it?
Yeah, so my year when I was a fellow, the other three fellows, if you were to ask them why they were doing the fellowship, I think all three of them would have said OMM to get better. I was kind of the black sheep in that regard. My first answer was I want to learn more about education, more about teaching, and the OMM was kind of a bonus for me. So I got to do a lot of OMM, but at least at our school, part of it is, we earn a master's in adult education as well, doing coursework with Troy University. And then we also get experience going to every anatomy lab, giving a couple lectures. And so because of that, I think that for me was the biggest thing that I got out of it. And so I definitely am glad that I did the fellowship. Yes.
Yeah. So a little bit jumping off Shane, a little bit not. I plan on being a rural family physician. I want to go to small town and eventually be paid in chickens. Like, that is my jam. So part of wanting to do the fellowship, yes, I wanted my hands to be better, because I do plan on being mostly self-sufficient whenever possible. So the more I can do on my own, the better. But also the education aspect is super important to me as well. Health literacy is something that obviously a lot of rural areas struggle with. And that's something I plan on prioritizing in my practice. This education degree, a lot of people think like, oh, you're going into academic medicine, you're going to want to like teach residents and stuff like that. I don't necessarily care for that all that much. I plan on mainly using what I learned through this educational degree to help my patients. We learn a lot of different strategies in teaching. So if one way that I'm trying to teach a patient about their hypertension is not working, I can switch to a different method and a different one until we finally figure out something that works for them. So for me, it's been more about the versatility side of things, and I've been able to use that even in our clinic here. So it's been an awesome year to say the least.
So for me, I'm kind of closer to Shane, I guess. So I want to be a family medicine doctor, but I want to be in a regular sized city and be paid in things other than chickens, I guess. So part of it, when I came into it, I was really interested in the OMM aspect of it. I wanted to incorporate it into my practice as much as possible, have OMM clinic days, do all that stuff. But now, as I've progressed more through this, and just from other opportunities that I've had being a fellow at ACOM, I've kind of really leaned into the educational side of it. So, I mean, depending on how everything works out, I really do see myself being like a professor at a medical school, hopefully teaching OMM or teaching clinical skills in general. We have a couple of good role models here who work half at the hospital and work half at ACOM. So that's a model that I I'm super interested in, and I love to practice family medicine, and whether that's through a school's clinic or through my own clinic and then working at a school as well, that sounds like a really good opportunity for me. So.
Awesome. We have a couple of questions from the audience. The first one is, how do you suggest people would to shadow when they're trying to work a full-time job, still having to pay the bills and stuff, but still get shadowing experience if they're interested in becoming a physician?
So something that I've heard back when I was applying to applying to med school, it's really about the quality of your shadow time and not necessarily the quantity of it. So if you can only shadow 1 week in a month for a couple of months, then that's fine, as long as you're making a good use of that time and making sure that you're getting valuable lessons and advice out of that time. So everyone has a different situation, and med schools definitely take that into account. If you have a job or if you have a family, everyone has different responsibilities. So, but just try to find whatever time that you can, I guess.
I'd say look into local clinics around you, like volunteer clinics. A lot of physicians take time outside of their practice to go and volunteer at those. And those are typically during hours that are not during regular business hours, because obviously the doctors are working. So they would have to come in different hours than normal to be able to volunteer there. And you find a variety of doctors that work in a variety of fields. I've gotten to shadow dermatologists, cardiologists, family medicine doctors, all with various different experiences by volunteering at those kinds of clinics. And usually they fall within hours that are reasonable for anyone's schedule.
So it sounds like, we just have to make sure that we go out of our, if we want it, we got to kind of fight for it. And I think all of us along this journey can attest to that. Not everything comes easy. You can't find a physician, can't find somebody to mentor you. You just got to look. And, there's people out there. And I've personally been blessed with great mentors who've been interested and excited. And I think I can say the same thing, DO, MD, doesn't matter, for all pre-medical students. Reach out, don't be afraid. We have some more questions from the audience. So the question is, has OMM been useful outside of your clinic? For example, any times that you've treated family and friends, and how have they responded?
Yes, 100%. For me, I mean, it's especially, family, if once you kind of explain what OMM is, and then they kind of get the idea that you can fix anything. But then, I try to always explain, okay, if I think the problem is this, I'm going to try this. Keep in mind, the setting might, if I don't necessarily have an OPP table or like a massage table, if I'm just, doing it on someone sitting on the couch, with positioning, it might not be ideal. But I just try to explain it and then, set realistic expectations. Plus they know they're getting it for free. So it's there. You'll find plenty of opportunities. And once your family and friends find out that you're a DO student, once they know what OMM is, you'll be getting requests to help.
So yes, definitely they will ask you to help them out. As a medical student, your family and friends and sometimes strangers will ask you for medical advice, and you will have to bashfully say, I don't know, I'm just a medical student, sorry. But OMM is one of those things that you can definitely kind of show off your skills. So family and friends, whenever I go home, I spend a couple of hours typically working on different people. So it's a fun time, and like I said earlier, it helps you become more confident with your skills. So it's definitely a good thing.
I have standing family appointments whenever I'm home. It's a thing. It happens.
It's almost like the moment they see your face, they're like, oh, this is hurting too. Everything is hurting. So it's just total somatic dysfunction just spontaneously occurs. But yes, it's usually family and a lot of family friends.
I would agree. After the first semester of medical school, you walk home, your family lays on the table and is like, fix me. You can figure it out, right? So yeah, it's not that simple, but it's really rewarding to be able to say like, okay, I'll give one example. A couple of years ago, I think it was the first year, my dad said that he had like a little pinch in his shoulder. It like kind of hurt, but not enough to like for swelling or anything. And I ended up doing the Spencer technique on his shoulder, and he's been fine ever since. And it was a nice like 30-minute thorough treatment, but it was definitely awesome just to see like, it was an acute issue. He just like pulled it somehow, but I was able to, restore his range of motion. And I know he's thankful for that. We have another question. As you practice, have you found that you've modified your OMM techniques to better fit the needs, or do you still typically use the same techniques that were used in school?
Yeah, so definitely, especially in internal medicine, if you're in the clinic, you kind of use a lot of the techniques that you are taught, especially the foundations. You start out with the lymphatics, and then you go on to the other counter strain, muscle energy, whatever you want to do. But then a lot of times in the inpatient setting, especially in like the ICU, you can't necessarily do a lot of muscle techniques, especially if someone's intubated, or even if someone is post-operative and they're just recovering, but and that you're medically managing them, but they're not as able to move their extremities or their back as much for you to do those active techniques, the direct techniques. So what a lot of times I end up resorting to are the passive techniques, where the patient doesn't necessarily have to do anything. And we just kind of slowly, gently guide certain somatic dysfunctions back into place if there's any dysfunction that's noted. A lot of times, the most common one that I use is for post-operative atelectasis. So in layman's terms, after having a procedure, you've been under anesthesia, and so while you're during the time you're in the procedure, the anesthesia everyone is your lungs are kind of completely not working as well as you would be normally when you're breathing on your own. So because of that, you kind of have to regenerate that muscle. And so at the end of after someone is post-operative, they get something called incentive spirometer for them to build up their own muscles or their own diaphragmatic muscles so that they can take deep breaths. A lot of times there's poor compliance to that, and reasonably so. It's uncomfortable. So because of that, when I do a passive technique, I just have them lay down and I kind of just perform any of the passive techniques that allows them to kind of ease into place, and then you see over time, you see them after for 3 days post-operatively, and they begin to show improvement. And this lends credence to the idea that OMT is not, you're not curing someone. What you're doing is you're actually enabling the body to heal itself. It's so you're kind of guiding it back into place, but you're not the cure. You're not the person that's responsible for it. The body's actually doing the work.
I think that was awesome, Anish. Thank you for, that's super practical, something that we'll all see, even if we're just on our IM rotation inpatient. If our attendings are fine with it, if we can learn a little bit better to be able to help them out. So we're towards the end of our talk. I just wanted to give everyone a couple of minutes to give any closing remarks or any last minute advice you wish somebody would have told you as a pre-med, and go ahead.
Just remember to have fun. Once you get to med school, it can be a long 4 years or 5 years if you do a fellowship. And just, a lot of times we go into it thinking, I think for the past 3 or 4 months, I've had a countdown on my phone with the number of days to go until graduation. But I do think med school is one of those things. It's not about the destination. It's about the journey. Yes, the destination is important because, we want to become doctors and help people, but just try to enjoy the ride best you can.
So the advice that I tell, so as well as we talk to interview students as well, and then especially when the first years came in, the advice that I give them is to make sure you take care of yourself. Med school is hard, undergrad's hard, MCAT's hard, boards are hard. It's a tough road to get to where you want to be. So make sure you take care of yourself. If that means cooking, then do that. If that means exercising, do that. If that means playing with your dog or hanging out with your significant other or your family, whatever that means for you, just make sure you continue to do that as much as you can, because grades are important, and you have to learn as much as you can, but you still need to stay human and need to be yourself. So just keep that in mind as you go through your journey.
Hunter?
Yeah, so mirroring off of Jonathan, yeah, do the things that you need to do to keep being yourself. It is very, especially getting into medical school, it's like drinking from a fire hydrant. Like, you get overwhelmed by the amount of information. If you are not taking the time for yourself that you need to, it will end up drowning you. You do need to do the things that help keep you sane. For me, that's music. I'm involved with a local choir. That's how, like, once a week I go spend time with them, and that's how I get out of the midst of all the material, I guess is the best way to put it, to just refresh and reset for everything else that comes throughout the week. Just taking that time for yourself is so very important.
Agreed. And also, definitely do not be scared to ask for help. In case you didn't hear from everyone else, this is a very difficult path you're on, or you're going to be on. So everyone understands that, and you're definitely never in this alone. So there's always someone willing to help you. All you got to do is just ask. And that's the hardest step. That's what I found was the most difficult, was knowing when it's time to ask for help, because people are there.
All right, thank you guys. I feel like this talk went great. I hope you guys enjoyed talking to everybody. I hope the audience enjoyed it. I think you guys shed a good light on what is OMM, how can we actually use it in the clinic. You cleared up my billing question. And, I appreciate you guys all being here and doing this talk. And thank you, AMSA, for allowing us to, put this whole thing together. We wanted to use AMSA's platform because, there's a lot of medical students here who are on the fence and don't know where to apply, don't know what they should do. And I hope that this can provide a decent amount of insight for all those students. So thanks.